Good afternoon from Alaska. Thank you for attending this webinar. I'm very, very passionate about, of course, airway and dental sleep medicine. And I believe that it's connected to everything that we do, from bread and butter dentistry to smile makeovers to implant dentistry, as well as the overall care and the quality of life in your patients. So let me go ahead and see if that slide works. Okay, I'm going to start with just the disclosures. So generally, you can see I'm involved with a lot of different companies. I do speak for different organizations and in part of a lot of boards. Actually, I'm asked to be in other boards for sleep academies, but as far as with Microdental Max Studio, I am given an honorarium for this lecture, but there's no like financial gain or anything like that other than the payment for that. Then the next thing I want to go over is our very first slide, which is the most important slide. I want to say, though, before I begin, is that there are going to be more than enough slides for this presentation, for sure. It's actually, I'm hoping first to get people to participate and to ask questions, because I'm hoping that with this statistic up there, that more dentists, there's far too many people in the world who are underdiagnosed, undertreated with sleep airway related breathing disorders, right? And so if you guys can actually start looking into this, whether it's screening or doing actual oral appliances with Microdental, that's my first goal. Second is I've spoken to Laura and the great people over at Microdental Max Studio, and they're interested in having me do a live seminar, perhaps maybe this fall. The final date will be organized later and then disclosed, but to also motivate you, if you would like to do a face-to-face seminar in Livermore, that would be something also. So after some slides and maybe just little information, so I will pause a bit, and if there's any questions, please raise the emoji, and then you can directly ask. I'm happy either way, whether Ten reads off a question or you ask directly. But I want to stop right here with this slide just in the very beginning, because I want to say that when people think about perhaps competition, or think about how can their business grow, how can they thrive, sleep medicine is, first of all, the wave of the future, because it's also tied to our Hippocratic oath. When we got our degrees in dentistry, we had an oath to do no harm, but also to do the best we very much can with our greatest potential. So it's important that we look into in the very beginning every patient's medical history, because there are already in them red flags that you should kind of link airway and issues, even with the long-term success of your dentistry. And there's some slides later that we can get into that, but yes, our restorative dentistry, whether you do a filling or a crown or even a veneer or an implant, there's going to be a lot of forces, and when a person's asleep, especially during REM sleep where their body is paralyzed, and if they have oxygen desaturations and it becomes a fight or flight issue, they're going to have sleep bruxism or all sorts of issues, movement disorders and stuff that can affect the long-term success of our restorative and our dental work. So at this juncture, does anyone have any question with this slide? Okay, so I'll give it a few seconds, since it seems like there apparently is no question, so I'm going to go right ahead to the next one. When I give a seminar live, this slide is actually done to show the prevalence of airway problems, right? People who have either upper airway resistance syndrome all the way to full-blown sleep apnea. So what happens is, I'll ask the audience to raise your hand and keep it up if one of them pertains to you, right? And this is the first one's, of course, if anyone's snoring. Generally, a lot of people raise their hands with that. But of course, there's also really fit people without high BMI index. And then, some people then notice that they clench or grind at night, and definitely family members or children. Some people wake up with morning headaches, especially if they're waking up with morning headaches. It's definitely a sleep-related issue. And you can see in the literature, whether it's hypertension all the way to Alzheimer's dementia, there's a direct correlation and link to airway issues, breathing at night. high blood pressure, strokes, all those things. There's statistics, and there's anytime if you guys need information, feel free to email me on references and things like that. I'd be more than happy to do that. But what this is, when you get to the very end, is that you will see that 99%, almost to 100% of the people in the audience will have their hand up. And so just thinking about that, and you contrast that to the awareness of sleep apnea, you'll find that, it's real shocking that, so many times people have issues. Myself, before I, treated my own sleep apnea and airway issues, I had acid reflux, hypertension. I was on a loop diuretic and ACE inhibitor, as well as Nexium. And so those things are, very much related. And, this is where we can actually help the patients and dive into their airway issues. Are there any questions regarding this slide? Yes.
We have a question, 2 raised hands, one from Paul Lippy and one from Dr. Jinglai. So
perfect.
Dr. Paul, if you could unmute yourself.
Yes,
again.
Hello.
Hi,
yeah,
Dr. Paul.
Hi. So, yes, my wife complains of headaches, but I've always attributed it to her clenching and grinding, since her masseters are really very tender, and it seems to be in her temporals and her occipital type areas. So could that be still related to a sleep disorder?
Absolutely. Well, so first of all, let me get into what happens, right? So when we get into it, so in a hospital, if you have oxygen desaturations to 90%, the nurse is supposed to push a crash cart. That's how serious this is, right? And we hear of actually people desaturating to even lower, like 70 and 80s. It's a miracle that the body can still survive from that. But on the other hand, we see in the news celebrities from Reggie White to Justice Scalia who don't. They'll have their supposed CPAP, or they're intolerant, or they're only using it for a few hours. But what happens is you are supposed to be in parasympathetic, right? And if you imagine, if I were even an upper airway resistance syndrome where you have only microarousals, but imagine you oxygen desaturates, your body is on fight or flight mode, and it shifts to sympathetic. Not only do you have this cortisol cytokine inflammatory response, but all of it, yes, will end up with headaches. There are so many patients that we've seen, whether they have a customized oral appliance therapy or they have orthotropics, such as the craniofacial epigenetic pneumopedic modality, or the fixed axial restore, or the Wan Moon MSE skeletal expander. Those things that actually address airway, some of them actually change anatomy, some of them actually put a patient in a therapeutic position, which, for example, Microdental offers the Respire customized appliance, will definitely help with headaches. But if there are TMJ issues or TMD problems, sometimes there are different orthotics, there are different TMD splints. I look at airway as a 24/7 thing, because even when you are awake, your oxygen can desaturate, and oxygen is life. Oxygen is so important, and so when you have all those deficits, the literature now shows, whether it's a migraine headache, cluster, cervical, or any issue related, it's the body's repeated attempt, to survive, to get the air in. And how sleep bruxism works is like this. Okay, in the literature, if you were to cite a couple of them done in Canada, their conclusion is that there's no direct positive 100% correlation to say that, yes, if you have sleep apnea, you're going to have sleep bruxism, or if you have one versus the other. However, every sleep center, I've seen a polysomnogram, and almost every certified polysomnogram technician I've spoken to, when you look at the raw data and you look at all the different sleep stages and the cycles and whatnot, every time you see apnea or even a hypopnea for a while, you'll see that the body is trying to attempt to open a patent airway. You'll see that the abdominal region would actually do efforts. You see effort belts during a polysomnogram or a sleep test. It's showing that, and that's how acid reflux occurs, right? And so That's a very nice question. And by the way, please, anyone, there's never a dumb question, I really believe, because generally when I'm at a seminar, and I used to be really shy, but later people, tell me, oh my God, I'm really glad that you asked the question because I had the same, issue. So please, there's never a dumb question. And so, Paul, I hope that answers your question in that I can sincerely feel that in dental sleep medicine, we do have incredible things that are just, I've taken children who were labeled and diagnosed with ADHD who would have ended up being on Ritalin, which is speed, or Adderall, and then deal with a label when all they needed to do is breathe at night so they can thrive and grow. Actually, in certain modalities, you can see once you address with myofunctional therapy and nasal breathing for nitric oxide, you can see swelling go down, including tonsils and adenoids. So it's really remarkable. You have parents coming in going, oh my goodness, wow, my child's in sports now. They're no longer flunking in school or being disruptive, or it's crazy. And then with adults, wow, there's actually one pool of patients, and it's related to the upper airway resistance syndrome. And I really want to just add that in there now for people's information, because sometimes you'll see these patients come in, and generally over 90% of them are women. They're women between the ages of like 21, 22, all the way to premenopausal, the mid 50s-ish. And they're actually very, very much in shape. Okay, so if you were to line them up, the classical stereotypical view of airway problems is someone who has a high BMI index, they're overweight. So for sleep medicine, definitely do not judge a book by its cover, because these women are suffering and oftentimes they're neglected. A good example is I actually saw a marathon runner, and she had an AHI of 110. That means she stopped breathing 110 times per hour, and her oxygen saturations were crazy. Her heart rate was incredibly high. She was very, very, on a spiral condition towards death, right? So the UARS, upper airway resistance syndrome, is tricky. Why? Because generally these women, they're tired all the time. But when they have a sleep test or a polysomnogram done, they come back with negative results. They have an AHI below 5. The problem is AHI, which stands for apnea, hypopnea index. They're gauging that, which is really an insurance number. It's a medical insurance number, so they can, diagnose the severity of OSA, et cetera, et cetera. It's nothing more than that, but it's really not a full picture of what's going on at night. So these women, they'll, sometimes come in and they'll have fibromyalgia, or they'll have really, anxiety or depression. And they just said, I'm not the same woman that my husband says he married, and I don't know what's wrong. And, sometimes they'll be crying and they'll be asking for so much like help. And they say, I got an MRI, I went to this doctor, I went to that doctor, and, they've been dismissed. The problem is oftentimes, people in the medical community, especially sometimes, very busy board certified sleep MDs, they won't look at the raw data. They won't look at the RDI. They won't look at the microarousals. The definition for apnea hypopnea means that you have to have that event last longer than 10 seconds. However, if you have an event that only lasts 8 seconds and you have it happen like 200 times at night, and I always explain, if I were to choke your neck 200 times a night, do you think you'll wake up, feeling refreshed and normal? Of course not. And so with these upper airway resistance syndrome patients, we as dentists, it's tricky. I think only in New Jersey state, and I think Georgia's tried that, but definitely in Alaska, we definitely can take the results of a home sleep test. We cannot diagnose. Definitely, number one, make sure in your insurance carrier, everybody knows, because this is a medical condition, we cannot diagnose. However, when we're, breaking down a home sleep test or a polysomnogram, or you're looking at their oxygen desaturations, or looking at these events and scoring them and looking at them, for the patient's information. First of all, they'll be so appreciative, because so many times, how sometimes when we do like certain dentures, right? It's like, you make a nice denture, everything fits fine, you're chewing great, you like the aesthetics, it's like, goodbye, we won't ever see you again until you need a reline or something. Oftentimes in sleep medicine, it's like that with the Cpap, here you go, come back for your new parts and, new masks and whatnot. But other than that, everything's all, scored, and the compliance chip is there. So it's kind of like that. So they don't get the actual explanation. So we as dentists, when I do it and other colleagues who are into sleep medicine do it, they're kind of just entranced with what we have to say, but also so appreciative because no one's ever taken the time to explain that. So There's another question that was raised, so I should be fair if that's okay. Thank you, Paul, for your great question.
Yep. Thank you, Dr. Hu.
Oh, you're very welcome. The second question, if I can, Maxwell.
Actually, I'm not sure if we still have a second question present, unfortunately.
Okay, if not, I can move on. If it is, and you do attend to, just raise your hand and I don't mind answering any time. So yeah, please, this is, imagine this as a round table, like we're all sitting looking at each other. So please, I think this will make people more engaged, involved, and then definitely, you know, if we get to other issues, if you guys have a question later on billing we don't get to, feel free to ask. I may even skip around the slides. The main point is really to get you guys motivated to do this, because you know the world, there's too many people suffering from this. And one important point that I really want to show on this slide is it's 2.5, but actually when I was over at LSU doing one seminar, the medical school director came in and said that actually most medical schools, including residency, for a primary care physician, they have elective 1 hour presentation or talk on sleep. So unless you want to specialize in sleep medicine, and this is serious, I'm thinking, oh my goodness, right? One thing in America that sometimes is real tricky, and we all know it, is that it's too specialized. You never get the cardiologist, you know, speaking to the endocrinologist, speaking to the pulmonologist, and they're, you know, we're one body, everything's connected. And really, we should throw dentists in there. I mean, everything from our occlusion to our posture. I think also Atlas orthogonist chiropractors to SOTs to Rockabato physical therapists. These are things to create total health. And I think once again, with the Hippocratic Oath, our patients really deserve that. And so this, I want to share a story, okay? And then if there's any questions, I'll be more than happy to ask. So, you know, recently, my father in April, he's passed away. And one of the things that really, really bothers me is actually both my mom and dad. My mom is now on renal dialysis because her kidneys failed. But over the span of what I can remember as a child growing up, both of them snored. Both of them sometimes wake up in the middle of the night gasping for air. And, you know, it's like we don't know what we don't know, but oh my goodness, you know, I asked my mom and dad, I said, has there ever been your, you know, internal medicine doctor or even a cardiologist, have they ever asked about, you know, how you sleep, how well you sleep, right? Sleep is supposed to be 1/3 of our lives. We're supposed to have, as adults, 7.5 to 8 hours of sleep, 7 nights a week. And I also want you, when you please speak to your patients when they say, oh, well, yeah, I've been diagnosed with sleep apnea, but I use a CPAP. I want to say, ladies and gentlemen, please, please make sure that if they are on the CPAP, and we know this to be true, they need to be compliant 7 nights, not the Medicare standard where they're only 60 to 70%, 45 nights per week, not the only, you know, 4.5, 5 hours. They need to be at least 7.5, 8 hours every night, right? But anyhow, all of these years with my mom's hypertension, when she went in, whether she had a side effect to a medication or whatnot, you know, she wait sometimes for an hour or so. Then the nurse comes in and gets her. They weigh her, and then you know, the doctor will be in there. Maybe I would say 3 seconds, 4 seconds. Oh, you know, he'll say, well, oh, Celia, oh, you have an allergic reaction. Okay, let's just write this new prescription, in and out, and it's like, you know, $300-400 bill. It's like, oh my gosh, right? And that's sort of how medicine is practiced, and it's always kind of leaned towards big pharma. Everything is medication, medication. Here's a side effect. Here's an allergy. Guess what? There's more medication. And with my dad, he actually, the official diagnosis was a double whammy. It was congestive heart failure, which people get central apneas as well as obstructive sleep apnea, but also Alzheimer's dementia. When it got to stage 7, it crossed over to Parkinson's. So he was actually, you know, having tremors and shaking. And it was just really sad. And I'm actually very, very happy that he's no longer suffering. But I just get really, really mad that, you know, right now Stanford University has a whole bunch of literature talking about the beta amyloid proteins, right? And for this time, and they are doing a lot of progress with that. They're looking at the meningeal wash that's supposed to happen. I mean, if we're telling our patients that they need to come in for their routine perio maintenance and, you know, clean and wash their teeth, for, if you will, well, absolutely we need that to go on during a nighttime for sleep, because when that beta amyloid protein builds up, more important than the tau proteins, that's what's really linked to the Alzheimer's dementia. So it's very, very important that I think that if the medical community is not going to do it, we as dentists, I think could be a calling. We can make a difference in that. We can actually link these things together. And I want to say this very, very quickly about dental sleep medicine. I may have a slide, I think I do, that later goes into the details, but studies now show that with dental sleep medicine, what we do, the compliance rate, which equals long-term effectiveness and long-term success, is far, far better than PAP therapy. And, when we move the medical community, we have to move by literature, by studies, by, actual peer-reviewed stuff. And, that stuff is really building momentum. So it's really good news for us. Based on this, I hope that people can, when they start doing their recall exams, when they're reviewing their medical history, if you find red flags for airway, please have that discussion, because you can say, hey, there are dental alternatives if you're not Cpap tolerant. There's also things that, and I'll tell you, there are patients, when they come in, they'll say, my brother or my sister had a Cpap machine and they hate it, it was miserable, and they'll say, hell no, I'm not going to do that. Actually, what's really cool about that is there's a form that you can exactly write down for Cpap intolerance. And once you submit that to the medical insurance, they totally will understand. Sometimes they'll require, especially, with Medicare, when they turn in the Cpap machine, but hey, if they're not going to use it and it's no treatment, I'm more than happy to offer something alternative that they can use with better compliance and long-term success. So with this slide, are there any questions from anyone?
No question, Doctor.
Okay, so let's go ahead. So, we want to have this, I have this up because I really want team members really to kind of bring up, I have to say that one of the most powerful things I've learned as I went into dental sleep medicine, and you kind of know it too, just from doing general dentistry, that sometimes, you're the doctor when you're talking about a treatment plan. Yeah. Am I going to buy you the next plane or whatnot? I'm like, I don't even have a pilot's license, right? But I mean, but when a hygienist or an assistant talks about it, let me give you an example. Okay. So if the hygienist is really geared towards airway and has some myofunctional therapy training or whatnot, or they can do a stop bang form or a screening form. I have examples later, slides of the stop bang and other forms you can use. There's a watermark questionnaire, and it gives you sort of this risk factor for having airway issues, right? And so they'll get the measuring tape out and they'll measure the neck size. And then the patient may say, well, wow, Wendy, I've never seen you do that. What are you doing? Why are you doing it? And that really starts the dialogue, honestly, for them to talk about, airway. And then they can say as little or as much. But when you come in later to, connect the exam or whatnot, or the treatment plan or scheduling, that's such a golden opportunity. People often ask, if I get into dental sleep medicine, do I have to somehow, how am I going to get the patients? Where do I advertise? Well, I have to say, they're all in your own practice. Each year, there are studies, there's over 400 patients that walk through your office on average in the United States that need dental sleep medicine or airway treatment. But, and again, the American Dental Association, they wrote a flat out calling mandate that says every dentist should at least screen for airway and sleep breathing disorders and sleep apnea. And if you think about that, it would be uncommon or almost kind of like taboo right now if you were to walk into a dental office and there's no oral cancer screening, right? You don't have to have a Velscope or anything like that, but you're definitely going to look for lesions and stuff like that. And so, I hope, I pray, honestly, that it becomes the same for airway and sleep apnea. So does anyone have any questions on this, or maybe perhaps, how they can get their team involved or anything like that? Okay, so I'll go on. So this is sort of, I was just going to describe what we're going to do, but we already did that. So this is actually something that you guys can either Google or download, but if you have medical doctors in the community or even board certified CPMDs that are wondering what their rules and mandates and guidelines are, this is from the American Academy of Sleep Medicine. So this is their territory. And what they actually concluded was their dentists are given the okay actually as a first line option for customized oral appliance therapy to be done for mild and moderate sleep apnea. And so I have to say this though, even in severe cases, right? Sure, if they need to do, especially some insurance may require it, so keep that in mind. If they need to do a CPAP trial, it is different from insurance to insurance. Sometimes they need to do it for at least a month or give or take. And if they are deemed compliant or intolerant of the CPAP, that they're allowed to do oral appliance for severe cases, right? It's very, very important because let's think about the statistic, right? In 2018, there were 2 million people in the United States. Now, think about this. This is serious, guys, because this is everything from quality of life to all the medications you're taking, all the systemic stuff. That's all in your patient's medical history. This is real serious stuff, and sometimes it's very life-threatening, right? We know that. In 2018, there were 2 million people that they quantified that were CPAP intolerant, because the CPAP machine, they have like compliance chips and they know how long you used it or whatnot. And of course, Medicare has guidelines that show whether or not you've reached that threshold, whether you're compliant or not, et cetera. And if you're not compliant, sometimes they make you turn the CPAP machine in and all. But there were 2 million, right? But how many oral appliances were made? So how much of dental sleep medicine was involved? Well, only 200,000. So in the entire year of 2018, only 200,000. And this is the kicker of that, because if they're already CPAP intolerant, they already were diagnosed with sleep apnea. They've already done a trial run because they're CPAP intolerant. And so why are the, sleep docs not, recommending or referring them to us for a serious condition? Well, I have to say that sometimes, you can have a heart-to-heart with medical doctors and, have lunch and learns and whatnot. But, we really have to get down to the very serious aspect of this. I always, if you think of an example, because, we're in such a lawsuit-happy society here, but it's something, it's food for thought, right, for the medical doctors to understand. Because oral appliance therapy, dental sleep medicine, is a recognized and respected alternative to CPAP. Let's say a school bus driver who has sleep apnea, and this is like the worst imaginable situation, but this is something good for the medical world to hear, right? The MD world and the DOs and the ENTs and whatnot, is that the school bus driver went to go see the sleep physician and had sleep apnea, okay? And so all of a sudden, this school bus driver tried the CPAP and they failed and whatnot. He or she failed. And then the sleep medicine doctor just says, well, okay, too bad, and doesn't talk about these alternatives such as dentistry and dental options. And then the school bus driver gets in a car accident and kids are injured or things or whatnot because he fell asleep at the wheel. Can you imagine the ramifications? Can you imagine how serious that would be? Because the sleep MD is absolutely accountable, in my opinion, because he never talked about or spoke about other options. And if we care about the patient's overall health, which extends to everything like this, this is just a school bus driver case, but what about airline pilots? We hear it all the time now that shift workers, airline pilots, they land in the wrong airport. You will hear a train, the East Coast, many commute on the train drivers, that they even actually get this, Captain Hazelwood for the Exxon Valdez oil spill in Alaska, they found that the whole oil spill, right, that became world on world news, was related to sleep apnea. He had poor sleep apnea that was never treated, and so his decisions and his reflex time, all those things were all extremely lacking. So it's just good information to know. And yes, because this is to be diagnosed by a board certified sleep MD, and yes, because you have to work with primary care physicians, I would definitely encourage people attending to also engage. Sometimes, bring literature to them, offer maybe a lunch and learn or any type of communication with that. There are now, you don't have to do that as one. That's just one method I think that can build even more cases and a bigger dental sleep medicine practice for you. But there are plenty of wonderful billing companies. I do believe one of them actually is working with a microdentist Microdental. I think Gabrielle or Attain can find that information, where most of the, because medical insurance is, it's very, very tricky. It's different than dental insurance billing. However, there are companies that they may just on average take 10%, some take 12, some take 8, where they help you, through the process of medical billing, especially if you're thinking about doing Medicare. Slides later, I don't know if we'll get to it, but Medicare, be very, very careful, because you don't want there to be any chance or any type of Medicare fraud type of issue going on. It's very serious. It's a federal offense. So everything, you have to think of it kind of like the 10 Commandments in a way. Whatever Medicare says and do, you do. But then there's also options where you can be opt-in Medicare, but non-participating. And when we get to that slide, and again, if we don't get to some of these things later, it's okay, because we could do another webinar, or we can actually have a live course seminar on Microdental for that. And that would be great for people to attend. And again, if I don't always answer questions like right away, but every email I get, generally by a week, I'll answer them. So if you guys have questions, feel free to get a hold of 10 or someone at Microdental, and they can forward me those questions and I can answer. No questions at IC for this one, correct? Max, so I'm going to go on.
Yep.
Okay, so here's a thing that, and I think you'll find all sorts of cases, and this slide is really, again, it's kind of like hey, how real is sleep apnea? And these are 3 kind of like reality TV stars. I think there, one on is Alaska's Deadliest Catch. One is I think a rap artist, and the other is a truck driver. They're on their mid-30s. They all have high BMI index, and the circumference size. So for men over 17 inches, that's a red flag. There are a lot of screening tools where they meet several criteria, generally actually being men, until you hit menopause. When menopause happens, then women kind of catch up to men in terms of prevalence for OSA and breathing disorders. All of them are diagnosed with obstructive sleep apnea, but the issue is all of them are no longer with us. They've all passed away. So again, this really highlights the importance that this is a very serious medical condition. And if they're not being Cpap tolerant, then there's going to be, some alternative that has to be looked at. As healthcare providers, we owe that to our patients. And this is just kind of a prevalence thing. But the main point of this slide, again, is to reiterate how little and how underdiagnosed and how successfully treated. I mean, you're looking at the pie graph and that little blue section. So the bottom line says less than 10% of OSA sufferers has actually been diagnosed. Of those that were diagnosed, less than 25% have been successfully treated. Earlier, I think last year, when COVID just became really, in the news, and people were all talking about, the first big death rates, where that was spiking at, and it was New Orleans. And I was just so eager waiting for any news channel to say, hey, maybe is there a sleep breathing issue? So you look at New Orleans, and what they found that most of the people who were actually maybe a high percentage or all of them were morbidly obese. Of course, I love New Orleans. I love the food there, but maybe a lot of the food makes people kind of unhealthy and whatnot. But if you're already overweight, and if you're already gasping for air, and if you're already having issues sleeping at night, you think maybe like adding COVID and perhaps those complications, not having your immune system robust because you lack sleep, you have fragmented sleep. You think there's some kind of thing, where, connected with that. So it's really, really sad that, people, the answer is there, the literature is there, but it's like, the elephant in the room that no one ever talks about. So it's really, really too bad. But, I'm on a mission, seriously, anytime when I do a webinar, when I was in Hong Kong or Malaysia, or doing any, we had these folks from, Copenhagen that came to Alaska, and they were really, really interested in this stuff because, it's all connected together. And I hope that this also inspires you guys to get into it. So this is a true, real thing. I mean, if every sleep lab, all of us did this, right? And 365 days a year, it would take 50 years just to diagnose that 1 billion, people worldwide to have it treated. So honestly, I get it, especially when a young dentist graduates from dental school now, holy cow, like they have debt up the wazoo, right? And they're worried about competition, but I promise you this, there's really no competition in sleep. There are far far too many people who have untreated, underdiagnosed. And you include the UARS people, oh my goodness, you know, and now there's literature coming out that's saying the UARS patients greatly benefit from customized oral appliance therapy. So all those anxiety, there's depression, fibromyalgia, all those things are treated with oral appliance therapy. Does anyone have any questions at this juncture in terms of the prevalence and how, you know, this is such a commonality thing? I can't believe that, you know, medical schools, and now actually my alma mater, University of Michigan, and I know Tufts already has a program. They're gonna, and I think University of Detroit, Mark Murphy over there, they're putting in sleep programs. So I'm really glad that that's going on. But there's really, and also for those in the audience who are thinking about, you know, getting close to retirement, like, oh my goodness, I'm gonna tell you, you know, I've done microdental nose. I do a lot of smile makeover treatment. I do implant dentistry. I do the whole 9 yards. But this is real. There are so many people I know that when they first start sleep, they maybe, you know, 10, 15% sleep, and then the rest restorative, right? And then eventually becomes 50. And I'll tell you, so many of them that's gone complete 100%, and they have like their annual gross better than ever they can imagine, but also better when they were doing the cosmetic and implant stuff, right? So it is very, very, and then also you get the feeling, see, for restorative dentistry, you can change lives, you can, you know, help people get out of pain and stuff like that, which is awesome. But in this situation, we're doing LC medicine, you can actually save lives, you can extend lifespan. And so there's literature to show that, there's plenty of examples to do that. So I'm going to move on. And here I'm going to start talking about the Cpap. It's important for you guys to know, earlier I said that the Cpap threshold, or what they use to be quote unquote successful, it's really a joke, because I think if we applied to any of that in dentistry, nobody would go to the dentist. You know, as dentists, that a little millimeter or half a millimeter means the world to us. We see a tiny overhang. I mean, and I think that's something we should be proud of. We should be, you know, excellent and strive for excellence with that. But Cpap has a 70% threshold, where if you meet that criteria, and sometimes just, you know, 4 to 5 nights a week, but excuse me, earlier, you know, we said as an adult, you're supposed to sleep 7 nights a week, right? There's all those sleep staging, there's all those, you know, recycling there from your leptin, ghrelin hormones related to appetite, to all the different immune system, your T cells, the robust, you know, to everything and anything you think of, your cardiovascular, all those things are interconnected, right? So what are you supposed to do on night 6 and 7, and you don't have the Cpap there? You can't call that success. You know, this is why there's such a high kind of hypocrisy there. And we really have to say and tell patients that if you're not doing that, you know, you could be in danger for a bunch of problems, systemic things to potential death. And it's just crazy that, again, our oral appliance therapy, which we have studies to show people are more compliant. I'm going to kind of get a little bit into that study and what I mean before I move on from this slide. So if you use your Cpap just for, like, you know, 3-4 hours a night, and let's say the oral appliance, you use it for, you know, not let's say the whole 7 hours, but you use it for 5 hours and you take it out. But you use your oral appliance for 7 nights. So the long-term effect, the apnea burden, the mean disease alleviation, or the SARA index will show that oral appliance therapy, what we do as dentists, the solution, the really it thing, statistically, in the literature and everything you want to go by, we have the answer. It's, I know we all, you know, went to dental school, we thought we were going to be only doing teeth and being tooth doctors, but I beg you, I beseech you all to know that we are really the key, because the compliance, the comfort, the effectiveness of what we do, statistically, period, whether it's randomized or any type of study, show that long-term effectiveness for apnea burden and everything is far, far better with what dentists do. Efficacy, sure. If you're going to put a machine that blows air and forces air into your airway, yeah, you're going to lower AHI, you're going to have some treatment. But if I'm going to pull the mask off, or if I'm not going to wear it due to all the side effects from aerophagia to claustrophobia to all these other issues, right? You're having zero treatment whatsoever in that. So we need to keep in mind, and almost in a way pat ourselves in the back, that if we do dental sleep medicine, we already have the literature and we have the proof that we're going to do something that really is going to have a long-term outcome benefit for the patient. Okay, and there's other things that I can talk about too that also mitigate some side effects, and also the follow-ups and things that we do, but we really can do much, much better than what's currently in the medical system. So I like to look at this, and this is, feel free to, print this out, or if you're going to talk to patients about how sleep works and what the sleep apnea is. I like to think of, when you talk about sleep, there's different stages of sleep, N1, N2, and then N3 and 4 is combined to N3 only, and it's called delta deep wave sleep. And then the REM sleep occurs. So two super important things to know is that the N3 delta wave sleep, first, most of the weird sleep issues, the parasomnias like sleepwalking, the night terrors, the restless leg syndrome, the whole 9 yards, they happen in N3. But N3 is also super duper important for Alzheimer's dementia. And this hits, close to home with me, of course, is because the meningeal wash that breaks down the beta amyloid proteins, or the plaque, happens during good, solid, consistent N3 sleep. So N3 sleep, you can be dreaming in that, but mainly you're dreaming in REM sleep. And REM, you're dreaming, and your brain is generally above 200% what it is normally when you're awake, but you're consolidating memories, you're doing all sorts of things to, recycle and organize in your brain. There are definitely cases showing that people, I think in Asia, they were doing too much computer games or whatnot. They had a lack of REM, and eventually they passed away really due to a lack of REM. But REM is so important because, it's our neurology, it's everything. It needs to recharge. If we're going to recharge our cell phones, we need to have our brains recharged. So it's absolutely critical that we do that. So if you have a sleep apnea problem, this is what happens. And this becomes a fragmented issue, okay? So if you look at this, when you have sleep onset, you have airway collapse, okay? So let's say it's a full-blown apnea. So you're actually very quiet, there's no breathing, there's nothing going on. Then all of a sudden, you're hypercapnic, too much CO2, you're not having enough oxygen, hypoxia, your oxygen starts desaturating, your heart works harder, even though, your body feels like you're running away from a bear, but you're just really sleeping and you're not even moving about. You may sweat, your heart rate goes up. That's not healthy. So all of a sudden, the abdominal region has increased ventilatory effort. So that's why when they do a sleep test, they have those abdominal belts. And this is where acid reflux comes in, because your body is trying to, if you see a patient doing a sleep test on a polysomnogram, you'll see the effort belts go crazy. They're trying to, and this is how the acid comes up. Well, if the acid comes up, guess what? Your esophageal cancer, all that, we all know about it. And then you have erosion, you have all these things that happen dental-wise that manifests itself when you're doing dental sleep exam. There's these red flags that just jump out, and it says, I'm screaming for someone to take care of my airway problems because all this. And okay, so night after night, you go through this cycle over and over again. So with this slide, I like to use the analogy. This is what really goes on, okay? I think of a playground where kids are in line to go down. Let's say their favorite thing is the slide, not the swings, right? So they stand in line, they go up the ladder, and then they go all the way down, and it's so fun. Okay, I'm going to go back in line. And so think of this circular thing, kind of like this diagram right here. So what happens if you slide down and you fall off on halfway down? Well, I'm sorry, little miss or little mister, you get back in the line and you start over again, and when it's your turn, you climb up the ladder. Oh, I'm sorry, okay, you go down halfway again, you fall off. Nope, you don't get to finish going down, you go back in the line. So this is what goes on when that, interruption is there, the apnea, hypoxia, the increased ventilatory effort, the arousal. Your body is trying to survive because, the oxygen's going way down. And then, at this time, I also want to interject one important thing. Okay, so when we check someone's bite or their occlusion, when we do our dentistry. We're looking at border movements. We have them tap, 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 protrude, go side to side. Great. Okay. And we know that if they did that lying down or they're sitting up, that also make a difference. But I want to say, excuse me, everyone. If you're in REM sleep and you're sleeping sideways or you're sleeping prone on your chest, your body's paralyzed. Remember, during REM, all muscles are atonic. They're paralyzed, right? And this is your brain recharging. And all of a sudden, you have this apnea issue going on. And your body is trying to fight for a pain airway. Well, this is where sleep bruxism can be like holy hell. And what I mean by that is there's pitch, there's roll, there's yaw, there's so many different things that you weren't able to check for during your occlusal check after your filling after your crown, that this is where a lot of times, I'm going to tell you two examples, okay? A lot of times where patients will walk in and you've done all the occlusion checks, and sure, maybe they were numb and maybe that could be an issue, but oftentimes you're like, oh my God, and you're like, yeah, this is just like a day ago. I don't understand how, they can feel high or whatnot, or how this can fracture or how this, I've actually had one patient who came in to me. This is before I did dental sleep medicine. And I even show this when I presented at the American Academy of Implant Dentistry, AID. And no joke here. Then since then, I've also had other people that had, as new patients come in, have the same thing happen to them. So this patient, when she presented herself, she had partial edentalism, and she had root tips, and she had abfractions, she had, melon potty 4, every red flag that's out there that that she has an airway problem. Okay. So, I don't know anything about airway, but I know she needs implants, and so I'm always, by the book. I definitely don't rush things. If we're going to do bone grafting, at least allow 3 to 4 months. If we're going to do implants, at least 5 to 6 months for osseointegration. So she had those things done, okay? And I just actually only did 3 implants at this juncture before this disaster happened. And it's already like her mouth was saying to me, okay, Dr. Hu, you cannot think that you just put an implant inside and then all of a sudden my airway is going to be like perfect. Yeah, the two are completely separate, related things. And she's been in function for 1 full year. Okay, so it's been in function, it's osseointegrated. She even came in for, period maintenance and stuff. And then one day she comes in and I'm like, there's just no way. She came in after she woke up, and it was like maybe like 10 or 10 a.m. in the morning. And in her hand was half of the implant fixture, not the abutment, the fixture. I'm like, holy cow, with bone and blood. Okay. She had such severe bruxism, such load. And remember, in implant dentistry, it's supposed to be all on the long axis of the implant, right? Well, good luck with that, because if you're sleeping with a pillow sideways, or you're sleeping on someone's arm and you're in REM and you're all of that, you can imagine that if you're trying to fight for a patent airway. And this is, I tell you, as I'm all experienced in this will know, sometimes you're like, what the heck? Patients say, well, I truly am, doctor, not eating anything hard. I promise you, I wasn't like, biting into metal bars or anything like that. I just don't understand, how did this fracture? And you're like, well, I don't get that. I mean, I checked occlusion, I checked for interferences, I checked for torque, I checked for premature contacts. And this is where really, we need to look into sleep, because sometimes when, fractures happen, it really isn't the lab's fault. Well, it would be the dentist's fault if the dentist, now, if you don't know what you don't know, then you don't know what you don't know. But it's kind of this, if the dentist didn't look into airway, because there's some crazy things that the body will do to keep, surviving. But definitely, if the lab made everything and you checked the excursions and everything to traditional dentistry, mounted on semi-adjustable articulars or whatnot, and you had your crown back and all those things were looked upon, and something still breaks, well, there may be a sleep apnea component. Nowadays, my whole team, they will not even entertain a smile makeover or a fixed hybrid denture or anything major unless the patient has full screening of airway. So I hope that this diagram really hones in on that aspect. I hope there are some questions for this to this juncture. Is there anyone with any questions? Please feel free to ask.
Yeah, please remember that this is a roundtable event. So if you have anything that you want to contribute and further the conversation, please feel comfortable to. However,
Okay.
so far we don't have any questions.
Okay, no problem. And again, please remember, there's never a dumb question. And I really just want you guys to learn, engage. Some of it may be review, but it's always good to have review as well to just know how you can really dive in and do dental sleep medicine. So here's some pictorials about, and I'm going to actually run through these 3 slides when you think about what we use as analogies to let patients know about airway. So you can see that when you have a pain airway, it goes through, it'll get to the lungs, there's nothing obstructing it, right? And then snoring, sometimes you'll just hear the noise because there's other soft tissues, you don't have a full collapse, and then you have all that, and then the velocity changes, right? So obstructive sleep apnea is when you have full blockage. And this is where we all have to think of a Starling's resistor, right? So we're looking at peak crit, we're looking at flow. So the analogy I like to use, and you guys can take notes or whatnot, but people really get it when you use it this way. We're, as human beings, born with 2 possible types of hoses, okay? And that hose is an analogy for our upper airway. We either have a garden hose or we have a fireman's hose. So if you think of a fireman's hose without water, gushing out of it, it becomes flat and you can roll it up on the fireman's truck, right? A garden hose, when there's no water coming out of it, it retains its shape. And for some of those lucky people, which is the far, far minority, who don't have any airway issues whatsoever, they have a garden hose. So if there's no peak crit or if there's no, it retains its shape, it's not collapsible. But if you have a fireman's hose, then because it's collapsible, then we have an issue. And especially during REM and you're sleeping supine on your back, and then gravity becomes our biggest enemy, and it pulls that tongue, it pulls the epiglottis, pulls whatever soft flaccid tissue down. We have a posterior extent, guys, a posterior wall. That's the limit, okay? And when a soft tissue goes and blocks that, I'm sorry, the air, the blue arrow you see, it ain't getting to the lungs. And then so your red blood cells, your hemoglobins are saying, excuse me, where are the oxygen molecules, And then pretty soon your brain's like going, uh-oh, not much oxygen, uh-oh, I can't go through that cycle anymore. I cannot, repeat and go through that. I'm gonna eventually die, and then I'm gonna now need to shift to sympathetic. Okay, body, do something. And this is where movement disorders and other things happen. This is also, restless leg syndrome. There is actually a component with restless leg syndrome. So if you have patients who have that, remember to ask them about their ferritin levels, their iron, and sometimes when they're iron deficiency, they may tend to have a higher restless leg syndrome problem. But also this whole thing, connection of airway and what your body does to try to survive, you betcha, it's a taxing on the entire systemic makeup, your health. It's taxing on the dentistry that's being done. It's taxing on so many things. So it's very, very important that we understand that and be able to explain. I always believe, seriously, sometimes if you guys take the time to tell patients, if you're especially doing beautiful veneers or whatnot, and we don't look dumb or like we're trying to find an excuse when we say things in advance, when we prepare the patients in advance and say, well, Mrs. Jones, we want your smile to be beautiful. We want it to last. It's going to be an investment, and we want to do the best job. We're going to use a lab that's very sensitive to polychromatic, to translucency, and you do all this beautiful work. You have beautiful margins, beautiful impressions, and, it's just a beautiful result. But you don't say anything about airway, and then they've, a month or 2 or a year later, some of these like just fracture in half, and then they say, well, I wasn't anything hard. I don't understand. Like, was there a material defect, or was that, yes, there could be. I'm not saying there can't be a material defect or whatnot, but one of the things that if you just completely ignore the sleep issue, that may be a very, very important thing to not neglect. So yes, apnea, full-blown apnea is a full flatline event versus hypopnea, which is partial. And there's different definitions of that. So a very, very important paper that just came out January of this year. It's from the government, actually. So I've earlier alluded to the fact that Cpap tolerance is very, very low, and that there's issues with compliance. This is actually 155 pages. They're asking for a part 2 of this, so it's not the full-blown thing. But the government, this is the government, they commissioned a whole group of doctors to do all the retrospective collaboration studies regarding CPAP. And the conclusion is very, very damning for CPAP. Not only the criteria using the AHI, which I earlier said is just an insurance number, it shouldn't be used to really quantify the success and the long-term better quality of life improvements that's supposed to be happening when you're doing, treatment of sleep apnea the correct way. That's not there. But the whole idea or notion that CPAP is something, wonderful. Remember, CPAP is a $7 billion industry. I think there's a slide coming up with that. So anything when you get to those kind of numbers and that kind of money, you got to think about the lobbying, you got to think about the power behind it, you got to think about big pharma. I get that, but once again, I'm sorry, I'm wired this way. We go back to our Hippocratic Oath and what we're supposed to do for patients, for their health, for their long-term outcome. When I go to bed at night, I just want to feel that I've done everything I can to do the best I can and to help my patients out tremendously. But the conclusion, which is so awesome in the sense that it gives us now an open window as dentists to really go in and show the world that we can be effective and we can give something that is going to be used for long-term success. We're talking about the apnea burden, the mean disease alleviation, and all those things tied to that. Even something like this, when I lectured in Hawaii, there are a lot of military bases there, right? And this kind of got me a little bit emotional because, here we have these military men and women who are really, defending our freedom and out there, for our country, right? And it's really sad that the Army says that if you are a great soldier, you don't sleep beyond 4 hours. If you sleep beyond 4 hours, there's something wrong with you, you're too wimpy. So that, of course, is really like crazy. But then, if they're asked to take these CPAP machines with them, they have to get those solar panel charged ones. And I'm like, well, good luck if you're in Afghanistan or somewhere, whatever, and there's overcast skies, how are you going to charge that? Number two, they're in these bombed out shacks, right? And you think, oh, they're sleeping on bunk beds and they're just enjoying themselves. No, they're not. They're actually in a very, very crappy area. And if 10 people have to sleep together in this one bombed out shack, 2 of them snore, 3 of them gasp for air, and they only have 4 hours to sleep, I'm thinking, oh yeah, and we expect these people to drive tanks and they have to be combat readiness, they have to be able to fly helicopters, what's going on? This is like ridiculous. So when I was there, the Colonel Neal, he came out with his uniform and he pulled an oral appliance out of his side pocket. And it's crazy because, these people, they have migraine headaches, they have all these issues, and they know they're plagued, and they're trying to use a machine. And again, it's also very heavy. So if you're walking with your backpack with a CPAP machine, I'm like, holy cow. So we as dentists really, you think about it, shift workers, the military, everybody, we have such a profound ability to make the quality of life, the health of people so much better. So it's something I'm so passionate about. And I think that every dentist who's attending this has definitely, if they're interested, the potential to do the same, to increase lifespan and decrease all of that. Does anyone have any questions on this slide?
Dr. Hu, we do have one by Jack. The main concern that's prevented me from getting into sleep dentistry is concerns about this device causing malocclusion. Could you share your experience regarding this, or would you recommend that I take some hands-on courses?
Very good question. And actually, the answer is very broad, so I'm going to go into it, but please pay attention. There are certain oral appliance companies that are doing studies. For example, the University of Pacific, they did a study on the materials used. And so knowing these things and putting together can kind of mitigate most of these issues. But I'm going to say this, that there is a whole wide range of different appliances with different materials, ranging from, cold cured PMMA to controlled cured PMMA, ranging from nylon to medical grade. So all of that, it does matter, first of all, but number two, it gives different types of pathways, if you will, to make sure you minimize those side effects. So Is it correct that a lot of oral appliances in the past actually have created these side effects like occlusion, bite changes? Absolutely. This also made the American Academy of Dental Sleep Medicine, ADSM, really put a huge, strong guideline out there. And I'm very serious with this. If you follow the guideline, I've never seen seriously an issue with movement or changes in occlusion. And it's also the therapeutic position that you put the patient in. It's a complex thing, but please bear with me on this, okay? So if you go to most schools of thought or camps, whether CR, ranging from Dawson to Spear to Coyce, or you go neuromuscular to Chan to LVI, whatever, okay, all of them would agree that AP, that dimension, is the least favoring for TMD and for occlusal pain issues. But vertical is very, very forgiving. The goalpost for vertical is very wide. So I actually did a paper that got published in AGD's peer review that talk about the vertical aspect and customized oral appliance therapy. And so my point is oftentimes traditionally when dental sleep medicine was first created, so many dentists only used one thing. They used the George gauge, and they only looked at one dimension. So when they tried to find an answer, they oftentimes tell the patients to calibrate or titrate, or they, as dentists themselves, calibrate, and they just jetted the jaw forward. And again, we know that AP is not forgiving, and if you're going to do that, you can do that night after night after night. Not only going to have bite changes, forces, muscles, things that are unhappy, you're going to create an issue. Right. So the conclusion of my paper, it was a case series study, so it's not randomized control. I'm in Alaska. I don't have that many patients, but out of 30 consecutive patients, 28 remained in the study, 2 moved away. So out of 28, I was able to reduce up to 4 to 5 millimeters of protrusion by looking at other dimensions such as vertical in the oral appliance therapy. So there's the oral appliance therapy position. That's number 1 to think about. Number 2, hard, rigid appliance materials. Okay, so that's the University of Pacific study. Hard, rigid appliance materials will, and this is the proof in it, because right now we have the technology to prove, even show the patients, so their jaw will drop and there's no questions to ask about it, is you will take a 3D on a Trios, on a Metascanner, whatever it is that you use, so you have it stored as a baseline, and a year or 2 or whatever later, you can take another scan and you can superimpose that. Then you can see how much change or movement or rotation, whatever, of anything, right? That's number 1, which is cool. And they found that rigid appliances in oral appliance therapy. And if you think about how a Vivera retainer in ortho Invisalign is so much thicker and so much stronger than your aligners that are, right? Because you're gonna, it acts like a retainer, it's very thick. And so there's a purpose to rigid appliance making. And the last issue about actually occlusion changes is this, is the American Academy of Dental Sleep Medicine says that because of these occlusion changes, you all need to do a morning occlusal guide or an AM aligner. It could be called either or, a morning aligner, MOG, or a AM aligner, meaning the morning. And this is what I always tell my patients. And when they do this, I also have, friends and both camps or whatever, CR, neuromuscular, that have little videos and instructional videos. And I tell my patients this, I say, well, Mrs. Jones, my job as your sleep dentist is try to get your airway as patent as possible, to hold a position in your mandible to keep the airway great throughout the night. But your job is to get your bite back every morning. And what I have done is my assistant has just scanned your CO habitual bite, your centric bite, whatever, okay? And it's actually into this AM aligner. I don't make my AM aligners chairside. I don't make cheap. I order an AM liner that's customized, and it has proprioceptive, it seats on the bottom, but it has anatomy on top. So before I even start any oral appliance therapy process, I said, put this in, Mrs. Jones, now bite down. Does this feel like your bite? Yes. I'm gonna tell you this, every morning when you wake up, right, I'm gonna have your jaw in a position for 7.5 to 8 hours every night. So like, if you're gonna take your appliance out, you go, whoa, like, yeah, it feels weird, and like, well, kind of duh. Then after you brush your teeth, maybe when you step in the shower, can you please put your AM aligner or MOGN, take your shower and go up, down, up, down, up, down. And I'm telling you, I've never, and it could be just me, I don't know, but I never heard of people who follow that recipe have any problems. Would they use rigid appliances and they look at things to mitigate those potential side effects? That's my answer. But my second answer with that question is good is, of course, if you can, go to seminars, whether there's so many different companies and groups, and I recommend. So for the three major academies, there's AADSM, American Academy of Dental Sleep Medicine. There is ASBA. I was just at Phoenix giving us a lecture at the main podium for the American Sleep and Breathing Academy. They have an annual session, generally in Phoenix or Las Vegas. And then there's the ACSDD. The ACSDD offers something that's really cool, especially during the COVID time, because they're the only online portal for credentialing system that's out there in sleep medicine. So they have these, like, yes, very long videos and stuff, but the written test and all of that, to get a diplomate or to get your fellowship, you do have to submit cases. And I totally agree with that, because, you know, you can't be sort of into sleep and just have like a tiptoe in it. You really should do cases, work with board certified sleep MDs, get some hours clocked in, you know, with sleep centers and stuff like that. But you don't have to go for the full diplomat. You can go for, like, you know, just a fellow or whatnot. Anyhow, they all have different things, but the ACSDD is all online. So it's at your own pace. And actually, if you enroll, I think I have a code, it's who something, you just do my last name, they give you a discount, and it's something worth considering, especially if you have a lot of free time, and it's, you know, you can watch the videos however, and then you take the test and you can credential through that. It's also very good because, you know, when a sleep medicine doctor, pulmonologist or ENT wants to say, hey, in my community, you know, who's, you know, they definitely don't want the people that just go through like a weekend course or just like a, you know, 2-hour lecture or whatnot and start doing sleep medicine left and right, because you're worried about, again, those side effects and how people, you know, deal with that. But like, you know, your question is awesome, because I do think that if you can and get to one of those seminars, then of course there's all sorts, you know, COIS has their own sleep now, LVI has their own sleep. Sleep Group Solutions, who I also, earlier disclosure, I do speak for them. We teach about the EchoVision, which is the pharyngometer rhinometer. And I'm an equipments junkie. People who know me know that I believe that everything needs to be measured. If you can't measure something, in my opinion, it's just an opinion. But if you can repeat measurements and look at landmarks and look at progress, and then have baselines and to look at different, you know, positions and whatnot, I think it's very, very important, especially when we're doing with something very serious as sleep apnea. Any more questions by chance on this? This AHRQ paper, by the way, is so awesome, because it really gives that chance for us dentists to really make a mark in the sleep medicine world. So Tian, you don't see any questions, right? Do you want me to go ahead and move forward?
Yes, please move forward. I do not see any more questions.
So I'm going to go through this really fast. Again, this is all the mean disease duration, and so there's facts and things like that that you can find. You know, earlier we alluded to that, and then we all found that in studies that you have to at least have 6 hours of CPAP usage in order to have a benefit from that. So when they're pulling it off at 4 to 5 hours, there's a problem. You know, I'll go through just some of these very, very fast. There are other options. Again, you know, other than CPAP, there's the dental sleep medicine or customized oral appliance, there's orthotropics, and you can get more and more invasive. So when you're talking about the MMA or the UPPP, the only problem with the UPPP is, and ENTs perform that, is that long-term there's a lot of relapse. And in the literature, if there's ever a test question, it's only 40% successful at best. So UPP, you know, they take away your uvula, the whole thing. It's a pretty painful procedure if you ask, you know, my patients when they say they're healing from that. But because of the relapse and because of that issue, it's not. Now, the maxillary mandibular advancement in the literature does show that out of all surgery, it is the most effective. It has like a 95 to 96% success rate. However, it's pretty invasive. I mean, you have like those metal extensions and whatnot, and you're literally kind of taking the maxilla and the mandible and then, you know, sectioning it and then moving it forward. But it's really big in Asia. All the oral surgeons there, they do, anytime people with airway issues, MMA. But just again, you know, surgery is irreversible, non-reversible, excuse me. And So if there's something that went wrong, plus it's not cheap, there's also a cost factor. Inspire is gaining ground, but a lot of the things that, I'm not trying to say anything negative about it or even really positive, I just want to kind of be neutral, but I want to give facts about it, is that all the literature that's out for Inspire is industry-based. So it's Inspire doing, studies for Inspire, which is fine, it still has that information in there, but there's actually criteria for Inspire. So Inspire is actually kind of like a pacemaker. So for those who don't know, it's a vagal stimulation and hypoglossal, okay, think of something else, but it's hypoglossal nerve stimulation. And so when there's an apneic event, then there's actually this thing that charges the tongue to make sure it doesn't fall back. But if you have a lateral collapse, if you have too high of a BMI, you don't qualify for it. And I think last I looked into it, it's about over 30 grand or more to do so, and you do have to have a healing time for any major surgeries like that, and the ENT does do that. So that's just something to keep in mind. And so we understand the prevalence, we understand that there's a lot that we can do. This is something very important right now too, to just keep it just a food for thought. They did this study, and we have a healthcare crisis in the US. I mean, every time we think about like national news and stuff like that, we know we have a problem with healthcare, right? And you think about whether it's, stimulus money or whatever it is that we're talking about, and we look at so many people who are undertreated or whatnot, or if they have Medicaid and whatnot, like we just gotta be smart, the average cost per person who has an airway issue because of all the comorbidities are going to, they average everything out through the United States and it costs them $6,366, right? But when you look at if they have CPAP or oral appliance therapy or anything intervention-wise to get their airway better, you reduce it down to $2,105 per year. That's holy cow, guys. I mean, this is really a major thing because we're talking about a more grand 30,000 foot, look at our country as a whole and the healthcare crisis. So if we know that all these comorbidities are attached to that, we really, really, really need to not just, brush off and say, oh, okay, who cares about sleep, right? So thank you for letting me say that on that slide.
A question, Dr. Hu.
Yes.
From Nancy Shiva, Dr. Shiva, are oral sleep appliances equally as effective as the CPAP?
So when you say the word effectiveness, oral appliance therapy are more effective than CPAP. CPAP is more efficacious than oral appliance. So once again, I'm going to try to, because I know it's confusing. Efficaciousness means if you have a CPAP turned on, now granted, if you were a 500-pound patient, you may have to turn that pressure so high, it's like an airplane jet engine blowing air in your face, right, that high, to really be at the critical threshold that you need for CPAP to be effective, right, which then again creates the compliance problem. So if efficacy, absolutely CPAP smokes oral appliance, right? Oral appliance is also plagued by, again, people in the past who only looked at therapeutic positions in one dimension. And when you have one dimension, not only do you have side effects, the side effects also equate to poor compliance as well. But when we're changing, we are in the 3D world, ladies and gentlemen. We have cone beam now that show that we're no longer in 2D, right? And when we do things, we need to think in 3D because everything that changes, everything that's our airway, everything that's our muscles and the whole physiology, everything is 3D. And so when we have those respected and we find a comfortable position and we test it with a post-sleep test or a polysomnogram to know that that position is effective and therapeutic, it is far, far, far better. And I'm serious, and the AHRQ paper agrees with that. The mean disease elevation, Boyd did a study, agrees with that. So this is not just out of my butt that I'm saying that. This is backed by literature and backed by analysis, retrospective analysis and everything that I feel very confident in saying that absolutely for effectiveness, long-term effectiveness, oral appliance therapy is better than CPAP. And I'm telling you, if the medical doctors or anybody goes into the literature and dives in and looks at that, looks at the SARA index, they cannot disagree. So that's my take on that. But one thing, again, I think, thank you for asking that question. I want to bring in and hone in on the importance of 3D, because this is why I think that when you jump into dental sleep medicine, if you take more courses, I mean, if you guys are interested and you tell Microdental that you want to see me live in person, we can do something like this as a big, 1 day, 2 day. We can bring equipment, we can bring, hands-on stuff and things like that, whatever. But I would love that more dentists are going to do this. But where I was getting at is, you look at the entire world of ortho, right? And I don't want to get into this too deeply because I can go on for hours, but it's very important. I'm trying, my point of bringing this up is how we need to respect 3D. You look at all the lateral cephalograms and all the literature for that, and you look at Sassoon tracings, you look at all those tracings that we talk about in ortho. We are talking about 2 dimensions. So when you look at Nasion to 8 point whatever, okay, and you're going to bodily and physically and anatomically change the patient with ortho or anything, a growth guidance appliance or a surgery or whatnot, I'm sorry, like your next lateral ceph, that's still flat 2 dimensionals. If you grow something 8 point Nasion, everything moves. It can move diagonally, it can move this way, that way. There's 3D, XYZ, diagonal. There's so many dimensions that are moving. So the answer really is ortho should really look at 3D, look at combings, not anymore these flat, and making ultimate conclusions about patients' face result, their smile result, their occlusion result in 2D. I mean, really, right? And so it's one of those things that I think that right now, because of combing and technology, we don't have any excuse anymore, if you will, to just be in the archaic 2D mode. Okay. Any other questions, Tan, at this juncture?
No, I do not see any more.
Okay. Well, thank you for those awesome questions, though. And thank you for, okay. So, yeah, and again, this is still kind of re-stressing the fact that we have, find primary care physicians and people who go and nobody, you have hypertension. Well, let's talk about the next medication that you need. You have a need to see the cardiologist. We'll do that. Oh, well, diabetes. Let's just go ahead and get you on, metformin and all these other medications and then when you have side effects and this and that, great. Let's just get you on more medication. And wow, right? I mean, I've heard somewhere, and I think this actually recorded, that one of the main CEOs or big shots of big pharma, they openly made it, says, we're not in the business to help people. We're in the business to meet our shareholders' demands and make sure that we give them more money. So, I mean, it's kind of like, okay. So, and then again, let's go back to our Hippocratic Oath, right? So those things just keep in mind. Actually, when I was in the American Sleep and Breathing Academy, colleagues, Dr. Anju Ili and Mona Patel, they gave a super fascinating presentation on women and airway. And there's just so many fascinating things. They talk about estrogen levels. And actually, for those looking into TMD, there are studies now that show, of course, during menopausal time, that the exacerbation or the level of pain and also airway issues combined in that area where estrogen declines is far more severe. But also, when you look at, pregnant women and you look at developmental issues with babies and whatnot, some doctors, such as myself, who want to go the extra step, we would really say to, especially, all pregnant women, but especially their first time, is just to do a sleep test, because it really, shows that you care. Because oftentimes, we talk about pregnancy gingivitis, we talk about all these other issues, whatnot, that we care for, or pyogenic granulomas, oh my gosh, right? But why would we not be, caring for the baby? Something also to remember, I always tell women who are pregnant that if you end up having a C-section, make sure that the doctor knows to take the vaginal fluid and inoculate that in the baby, because a natural childbirth, it's very, very important that when the baby goes through that, because we're talking about probiotics and all this digestive issue, and we're taking yogurt and this and that. It's very, very important that how the baby develops from birth, it's absolutely essential that that gets inoculated. Then after the baby comes out, we all know that we should breastfeed, right? not formula, but breastfeed. Now, if you look at studies that show how is Westernized society different and end up with patients or kids that grow up with airway problems and compensation, is that they looked into Aboriginal tribes, African tribes, and they always feed their baby upright. And there's something, you know, the only time that we can breathe and eat at the same time is before epiglottis does this thing, that fold, whatever. And, you know, you're suckling, on the breast. And when the baby's held upright, all the cranial facial signaling, the complex development, that's so important. And then when you're done with breastfeeding, you need to go straight exactly to solid foods. Solid, I mean, no Gerber baby foods, no processed foods, because that mastication, I'm sorry, just, you know, have a little carrot first, a little celery, make them chew, because that again is so important, right? And when we miss these things and we have mouth breathing, we have forward head postures, we have allergic shiners, that's when we get into the time where people start getting labeled, they have ADHD, they're either hyperactive or they don't pay attention or they fall asleep or they become mean to other kids. I mean, this all is very, very important for people to know. Does anybody have any questions regarding this at this juncture? Because normally when I talk about this, people kind of ask a little bit here and there. No.
Questions,
Okay.
Dr. Hu? No.
Okay, no problem. But just kind of, you know, that's food for thought again. So you can help your patients a lot by number one, telling them sort of, you know, what's best for their kids' development. Your patients will love you for that. But also if you do have availability for home sleep tests and stuff like that, or just encourage them to go to a sleep center to get tested because, you know, it is related to their baby and that. This is a very, very awesome, important slide because it comes from a neutral organization, American Automobile, AAA, right? And you know that actually, I think the DUI laws are the same throughout the US. I don't know if it's more jail time in other places. I think it's a one full day, one night at least of jail time. So if you're caught with a blood alcohol content of above 0.8 in Alaska, I believe, that means your license is taken away, you're in jail, you may have to have attorney fees, the whole thing. So it's serious. Absolutely, it should be serious. But AAA actually did a study. And first of all, the horrible thing is 21% of all fatal crashes are related to sleep deprivation. So when you look at the numbers of hours of sleep and you equate that to response time when how alert you're supposed to be while driving, you can see what that equates to how many, you know, alcohol or beer or wine, whatever that you drink. So if you have 4 hours of sleep only, and we're talking about like the military earlier and stuff like that, and they're holding a machine gun or something, like, wow, right? Or even driving a tank or something like that, or a helicopter. This is pretty scary, folks. I think we need to, you know, think about on the road, if you're caught by a state trooper or a police officer, that means you're going to have your license revoked. And yet, you know, we see, there's one video I've seen of a semi-truck driver. And that's actually so prevalent because their whole life is very, you know, stationary. They go from gas station to gas station, and they may not also eat the best foods. They may have high BMI index. And I know I'm stereotyping, I shouldn't be, but you know, they do have often sleep deprivation. And this one video showed that there was a construction zone, and the semi 18-wheeler was going about 65, 70 miles an hour, fell asleep. And I mean, wow, it was like an 18-car pileup, but the first 3 cars were smashed. So like, there's no way anybody in those vehicles were even possibly alive. But it's things like that that are so horrific. And you think about how, and you know, this study is out there, but you know, there's not much talk about how, you know, serious that is. I mean, we know, I remember 2 examples of when I was in college. You know, people always cram for exams, didn't sleep. And I remember some of the friends and colleagues and whatnot saying, yeah, I don't even remember like how I got home or how I got to school. It's like I normally would remember we passed by a stop sign or 2 or building, but I don't know how I got here. And you're like, oh my God, like this is crazy. Or other people, I've actually had people that say that when they're at a stoplight or when, you know, they're counting on other people to honk their horns to wake them up so they can, you know, be alert again to drive. I mean, wow, guys, like, you know, this is very serious stuff. And if you're in the wrong place at the wrong time, wow, this is really something, you know, but now we know this, you know, let's try to make a difference and let's bring that awareness out to the public. This is also very, very awesome. So Hung et al. Did a study And I actually have this laminated. So sometimes when I have to get to a real moment with a patient, in Alaska, we have these slope workers that come in and they'll say, I don't snore, I'm just fine. And my wife's, making me come here and I don't want to be here. And then, plus on their medical history, they may be taking hypertension medication. They may be taking all sorts of, this and that and whatnot. And, I said, okay, well, let's look at this study here. This is standardized. So everything's compared on an even, filter. Everything's all there done so that you can understand. And if you do any math, you have to think about this. So the chances for you to have a heart attack, sir, this is what I would say, serious heart attack, okay? You can have a high BMI index, overweight, and uncontrolled high blood pressure. Those two. And you're more likely to have a heart attack from having not treated OSA. Well, let's just change the thing around. Let's have you're a smoker, and that's actually a 20-pack year history, and you have uncontrolled hypertension, but you have regular solid weight, you're not high BMI. Still, you are more likely to have a heart attack, right? Versus untreated OSA versus that. So again, this is something very seriously. I mean, you know how much each year annually there are angioplasties, bypasses, heart issues related to all that stuff. OSA is scary. It's like that evil monster with multiple arms that plagues everything. And I don't care if you're talking about gout with nucleopeptide turnover to cancer, where they've proven that in an anaerobic environment, cancer cells metastasize far greater. So when you're looking at stage 3, stage 4, your airway is absolutely essential and important. So this is just a very good thing to have and definitely use to talk to patients. If you have a few things laminated during their medical health history review and whatnot, it's absolutely great for you to use that. Even I know. See, so oftentimes when I teach, they say, Dr. Hu, it's really interesting because it feels like you're a hammer and everything is a nail to you. And I'm like, I know, I feel that way, but if there aren't studies to back this up, and I have this one excellent optometrist up in Anchorage, Dr. Sherry Lentford, and she really, really connects all the dots together, airway, dentistry, and, yes, you can have, hypertension and glaucoma and issues with your eyes because, again, the whole body is in sympathetic overdrive, and there all the blood vessels, the endothelial dysfunction, the inflammation, all tied together. So yeah, even glaucoma risk is there with untreated OSA. Then we're starting getting into things like acid reflux. We see erosion, but the thing that I think about this slide is all the esophageal cancer and the other things that happen. And I'm sorry, like when I was, much heavier than I am now, and when I had untreated sleep apnea, it really, really sucked. I'm sorry, like, without Nexium, I had those episodes where I felt like my whole neck was like, burned or melted away due to the acid reflux. So it's so important that, you know that these are all signs and symptoms that show up during that. A lot of red flags. Every day we see, retrognathia, we see micrognathia, we see arches that are constricted. One good test is a cotton roll test. And again, it's backed by studies of people who don't have sleep apnea. The cotton roll, for some reason, is just magically like 38 millimeters. And somehow 38 millimeters is a very big thing when you look at the transverse dimension of the airway. So when I take a cotton roll, and I know it's that length, I put it on the cusp of Carabelli of the first molar to the cusp of Carabelli of the other one. And if that bends that cotton in any way, then we know we don't have 38, so there's a deficiency. All these red flags are important because, especially when you submit to medical insurance and you're looking at things or whatnot for justification, there's things, again, that all show up in the mouth. There's Mallampati score, Samsung-Young score, tongue thrust, ankle glossia, tongue tie, a whole slew of abfractions, all those things are there. And if anyone wants to get into details, that's actually where a lot of the conversations for airway is being discussed. Nocturia, especially in kids, they're so many patients, I'm honest, like to God, where they start, either I put them on Vivos appliance or any type of growth appliance with mouthwash therapy, literally this nocturnal bedwetting stops. It's just so amazing because the parents come in and go, holy cow, like I just didn't, think that the dentist can do something like that. And it's absolutely true. Again, earlier we talked about Stanford and how they've done the dementia, the beta amyloid proteins, then cancer risk and things like that. These are all studies that are available. And then we have, again, the issue with the $7 billion industry of Cpap and oral appliances. Should be a lot more done. So, and then when you talk about every crossover study, prospective trials, everybody would prefer an oral appliance over wearing, a big machine with a big mask. That's just kind of a given. And in Europe, where you find that they use a first line of care for oral appliance therapy, their statistics are so much better. You see on the bottom, you see USA at 6%, but when you see that they use oral appliance, as the top, you'll see that people actually treated much faster, they're much more compliant, and they have a healthier country as a whole. So one thing to keep in mind, though, the American College of Prosthodontics, they did do a review, and there's other studies that show oftentimes people go, well, if I brux my teeth, or if I just, have bruxism issues, let's just create a flat plane splint. And it's a very, very big important thing for people to be aware of, because there's evidence that now show, and it's kind of like a duh moment, right? There's evidence that now show if you make a flat plane splint and you're not using the material to hold a therapeutic position at night for sleep apnea, you can actually worsen the airway, because all that splint is doing is taking up space. And if it's flat plane and you're in supine and gravity takes over and you're in REM, guess what? It's taking up more of the space of the airway, it's taking up tongue space, et cetera, and it's creating a worsening effect of airway. So technically, that's actually iatrogenic damage that you're doing, making their sleep apnea worse. So please have, if you did a sleep test, there's really no apnea or no UARS, the patient's healthy and great, and you have some bruxism, fine, great, or you make something that's protecting them. There's also a reason why you think about a lot of these severe bruxers, but no one's ever looked in sleep, and they go through one night guard, another night guard, they actually grind holes through them. Well, this is where we need to step back and say, hey, maybe there's a lot of sleep bruxism going on. And, the patient doesn't remember because they're asleep or they're in REM and they're dreaming and stuff like that. But yeah, they're like, yeah, every morning I get up, my muscles are so sore. I have, muscle, even TMD or a headache or whatnot. And my guard now has a hole through it. Then it has another hole. Well, all those forces, added up, compounded, yes, they're going to create holes in the splint. So it's very, very important to have that in mind. So, actually, any questions right now, 10? No questions, right? Keep going. Are we good on time, or where? Pardon me?
We're at 6:32, 30 minutes over. So.
Oh, okay. Well, so maybe I do see that all the participants on. Maybe since we're a little bit over, I really enjoyed this discussion. I was wondering if just out of curiosity, if everyone can maybe just hit their raise your hand button. Was this a useful and helpful way to engage you guys and to have you guys asking questions and participating? I know we haven't gotten to insurance yet, and we haven't gotten to a lot of the oral appliance aspect. But if you guys can do that, just let me know, and we can do another one down the road or have a live event. I feel like if I just went through this entire hour and a half and I went blah 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 blah. And then sometimes what I don't like about webinars, because I don't have, is that you may have 3 or 4 questions, and at the end, all you do is like, oh, I have to pick the one question because I don't want to hog up all the questions and stuff like that. I think that if you guys like this, and if Microdental is interested and whatnot, we can continue or do whatever. So thank you guys very much for everything. Again, please, if we're at a round table, ask questions. And actually, if I do this physically, it would be so much fun if we really did have this kind of environment, and people can just, talk about their fears, talk about their complaints. Like maybe doing medical insurance billing is a big thing. What are some pearls for that, or this, that? I would love to be able to engage in conversation and offer some options for you.
I agree. That would be fantastic. Regarding our first question, I believe Elizabeth, Dr. Brennan, did you have a question?
No, mine was answered. Thank you very much.
Okay,
okay,
no
thank
worries.
you.
Next, Corey Allen. Dr. Allen, if you'd like to unmute.
I was just raising my hand. saying this was helpful.
Oh, okay.
okay.
Well, thank you. Thank you for,
Yeah.
Ditto for Chelsea Allen.
Yeah, it was wonderful.
well, thank you so much.
Yeah.
Thank you.
So, Ted, are we good then? And maybe you guys can get a pool sampling of the audience, and if they want some more, I hope so. You know, and I'm glad that you guys will listen to my stories and whatnot. But I'm trying to make it real, my own life experiences and stuff like that. So hopefully, you know, this encourages you guys to jump in. We really need dentists to start doing this and help save lives, extend lifespans, and things like that. So, thank you so much.